Hello, my name's Annette Evans. I work at Cardiff University Medical School. Today my talk is about asthma severity and whether there's effects on educational attainment at age 6 to 7 years. So the Welsh Government has an objective to improve the lives of all children in Wales. We know that nearly 1 in 5 children do not attain the expected level in education at age 6 to 7 years. These are Key Stage 1 assessments within Wales. We also know that more missed school days are associated with poorer educational attainment. So we thought, does childhood health impact on educational attainment beyond birth health status? In children, asthma is a common disease, and 1 in 10 children have current symptoms of asthma at age 7 years. Some teachers have commented that children with asthma tend to have more days off school when they have a respiratory tract infection compared to children who don't have asthma. So previous research has mixed results about whether asthma has a detrimental effect on educational attainment in this age group. The reasons why this can be because of the definitions of asthma. So are we looking at daily activities? Is it parental reported asthma or is it clinician diagnosed asthma? And also, does it include wheeze? Some studies included older children or teenagers where the effects may be different, and other studies did not adjust for important confounders such as birth characteristics and things associated with school attainment, such as school moves and other school factors. Previous research also highlights that respiratory tract infections are very common in children, and one study shows between 3 and 8 upper respiratory tract infections were found per year. The study aims for this project were to create more detailed categories for asthma using clinical administrative data and to investigate the influence of respiratory infections for children with asthma and the role of absence on educational attainment. So this project was part of the broad aims of the Wales Electronic Cohort for Children project. This was a project that linked multiple administrative data sets using an anonymised linking field, and the data is held in the SAIL databank. It was based on the Wales Demographic Service of names and addresses of anyone who has any contact with the NHS, and the National Community Child and Health Database, which is a Welsh database. It was then linked to congenital anomalies, and cleaning rules were set up to remove duplicates and errors, and then further linked to education data and health data sets. The cohort was set up as a platform to help inform the development of interventions that could reduce inequalities of children in Wales. So the asthma severity variables were set up as to be current chronic asthma severity, and we used management guidelines for control of asthma through the general practice prescriptions and diagnoses that were found either in general practice or within inpatient hospital admissions. So we created 6 categories. The first was intermittent asthma. The second, persistent mild. These 2 columns created persistent moderate, and the final one was persistent severe, which also contained whether the child had 3 or more oral corticosteroid prescriptions within a year. The final categories then were diagnosis only and no asthma. We also created a second set of categories with a broader definition that included wheeze. Further variables were created for further analyses, and we used multi-level logistic regression grouped by schools. So the results of our 85,000 children in the cohort, 12% had current chronic asthma between birth and Key Stage 1. Looking at their asthma severity, where we took the most severe category that they fell into during the years that we calculated, we found that 7% had persistent mild and 2% had intermittent bronchodilator, and that acute asthma based on inpatient hospital admission was found in 4% of this cohort. What was interesting is that across all the categories of asthma severity, we found that there were quite high levels of inpatient hospital admissions, but the more severe had higher rates, persistent severe having 69%. We then looked at the broader definition of asthma or wheeze and found that 21% of children had experienced this between birth and key stage 1 with a diagnosis in general practice or hospital admissions data, and that 5.4% had an inpatient hospital admission with acute asthma or wheeze. Again, we found a spread across the categories of asthma severity. So the results of the multi-level logistic regression were really interesting. We found that in the unadjusted models that there was an association between chronic asthma severity and not attaining the expected level at key stage 1. But once we adjusted the models for hospital inpatient admissions for asthma, for other respiratory infections, for birth characteristics including sex and deprivation and school factors, that chronic asthma was no longer significant. Hospital inpatient admissions, the measure of acute asthma, was still significant in the model and was an increased risk for children not attaining the expected level at key stage 1. We also found that 3 or more lower respiratory tract infection GP consultations was associated with not attaining the expected level in the adjusted models, and 7 or more upper respiratory tract infection GP consultations. So we ran some further analyses where we looked at the number of inpatient hospital admissions, and we also looked at the years of the child's life. So we looked at 0 to 2 years, 2 to 5 years, and 5 to 7 years. And what we found was, here we show the results from age 2 to 5 years, that if the child had 3 or more inpatient hospital admissions from the age of 2 to less than 5 years, there was increased risk for not attaining the expected level at key stage 1 with an odds ratio of 1.4. So they were 1.4 times more likely not to attain key stage 1. So this showed that increasing numbers of hospital admissions had a greater detrimental effect on their chances of attaining key stage 1. We found no difference for the chronic asthma severity categories. The results were similar to what we had found for when not split by age, and we found these similar results for 0 to 2, the years of 0 to 2 and the years of 5 to 7. When we used the broader categories of asthma or wheeze, we found this increased effect for 3 or more inpatient hospital admissions only occurred after the age of 2. So we also looked at the absence from school as a potential mediator, and we did find it was potentially a mediator between asthma and educational attainment. Throughout all our other analyses, apart from the one mentioned here, we found similar results for asthma or the asthma or wheeze category, which is quite surprising. So it's good news that asthma severity does not seem to be affecting children's educational outcomes, but clinicians and educators do need to be aware that inpatient hospital admissions for asthma or wheeze or repeated lower respiratory tract infections mean children may need additional support for their educational outcomes. For children with asthma, the association between lower respiratory tract infections and not attaining the expected level at key stage 1 was not above that expected for children without asthma, but more children with asthma had multiple GP visits for lower respiratory tract infection, and this indicates an accumulating risk. Thank you for listening to my talk. If you'd like to get in touch, my email's at the top of this slide. Thank you. Bye.